College, Puducherry. She has multiple journals. I also invite Dr. Geeta Lakshmi, consultant endocrinologist, Pragati Endocrine Clinic, Gomakshi Memorial Hospital, Chennai. He was the, she was the winner of ESI AV Award in 2019. She also have multiple journals. I request both the chairpersons to invite the speakers and take over the session.
Good morning, everyone. A warm welcome to Trendo 2020. I'm Dr. Jayashree. The diagnostic approach as well as management of several endocrinological disorders have undergone major modifications, and gynecological endocrinology made no exception. And today we have authoritative experts to address these topics, which have been influenced by ignorance and prejudices. So the first session of today is by Dr. Jayashree Gopal. She is present director of Endocrinology India and associate dean for teaching and research in Morgan Diabetic and Research Center, Chennai. She also has affiliations in SIMS Hospital and Sitapati Clinic. She has achieved Vocational Excellency Award from Rotary Club and Dr. Sam G.P. Moses Oration Award, APA Senate Chapter. And her major publications are in altered kinetics of circulatory progenitor cells and cardiopulmonary bypass associated vasoplegic patients, a pilot study. I welcome ma'am to start her session. Thank you, ma'am.
Thank you very much, Dr. Jayashree, and a very good morning to all the delegates and who have joined us. I'm just going to share my screen. Can you see my screen, please? Can you see my screen?
Yes, ma'am. I think you have to go to slideshow mode. Yes, ma'am.
Now you can. Now can you see the full thing?
Yes, ma'am. Yes.
Okay. Thank you very much. Thank you. Thank you. So my topic today, I'll try and keep it as simple as possible. It's on primary amenorrhea. An approach to the sort of diagnostic evaluation is what I'll be concentrating on mainly. And if we sort of go through some very, what can I say, systematic steps, there will be no confusion in the diagnosis. I think the most important thing we all need to keep in mind is amenorrhea is by itself only a symptom. It is not a diagnosis. It is not a disease. You need the diagnosis, the underlying reason why amenorrhea is occurring. So the first thing we need to determine is it part of a delayed pubertal process or is it part of some anatomical issue where the uterus is not developed properly? So if you sort of try and divide the diagnosis into these two main criteria, it becomes easier to think through the process. And just 1 minute. Yeah. So delayed puberty is defined as an absence or inadequate development of secondary sexual characteristics at an age by which 95% of children at that age would have normally done so. So it still means that 5% of children, it would still be a normal delay, but 95% of children would have started developing secondary sexual characteristics. So what age is this? We're all familiar with this. So either absence of thelarche or breast development by the age of 13 years, or absence of menarche really by the age of 16 years. So, of course, girls get brought to us by the age of 13, 14, 15 by anxious parents and relatives. But 15 to 16 years is 2.5 standard deviations above the mean. Or if thelarche, for example, started at age 10 years, but there is no menarche within 3 years of the thelarche. So most people will attain their periods within 3 years of thelarche. So any one of these would define delayed puberty. And again, the basic sort of way we look at it is it because of lack of LH, FSH, and therefore estrogen due to a hypothalamic or a pituitary or a ovarian cause, or is it an anatomic issue? So these are the two main categorizations of delayed puberty. Before I proceed with some clinical scenarios, I just want to talk about the various changes of puberty, it's a very complex process with sort of a lot of hormones which need to work together. So you have a primary hormone that is responsible for some pubertal change, but you also need normal levels of what I call permissive hormones for that normal change of puberty. For example, an increase in height, which is the most important thing we associate with the start of the pubertal process, of course, requires growth hormone, but it also needs normal levels of thyroid, cortisol, and estrogen to progress normally. Breast development, of course, the most critical hormone is estrogen, which is in turn dependent on LH and FSH. But we also need normal levels of testosterone and normal action of the testosterone for breast development. Pubic and axillary hair is dependent only on adrenal androgens, and uterus development mirrors breast development. So you need estrogen, but you also need the AMH getting turned off in the fetal life at a critical point. So AMH should not be present at that point in time. That will only allow the uterus and the upper third of the cervix and the vagina to develop. And if the AMH is not turned off at that critical period during organogenesis, the uterus development may not occur. But in addition, during puberty, you also need normal levels of estrogen, LH, and FSH, therefore, for the uterus to become bigger. So if you do not have estrogen, even though the uterus may have formed in fetal life, it may not enlarge and reach the normal adult size. So we'll go through several common clinical scenarios addressing different aspects of the diagnostic workup. Let's say a 16-year-old girl is brought to us with no periods. Her height is at the 25th centile for her age. Her weight is at the 10th centile. Her sexual maturity rating reveals a breast development of Tanner 2. Axillary and pubic hair is normal, and the rest of the examination is normal. Now, before we go into the lab evaluation, let us think about how we approach just the physical exam finding. The fact that the height is normal means that there is no growth hormone deficiency, so no pan-hypopituitary problem for the largest part. If she is short, in this case, she is not short. If she is short, we would consider either isolated growth hormone deficiency or Turner's syndrome, which is the other big thing which presents with delayed puberty. Growth hormone deficiency will not present with any pubertal delay. Isolated growth hormone deficiency, there will not be pubertal delay. The fact that if the breasts are developing normally, it would normally indicate normal estrogen action, which means that there is normal LH, FSH, and estrogen. If the breasts are underdeveloped, it means estrogen action is low, which could be either because of low LH, FSH, or less ovarian production of estrogen. Axillary and pubic hair is only related to the hypothalamic pituitary adrenal axis. So if the adrenal androgens are normal, axillary and pubic hair will be normal. So coming back to our case, her height is normal. She has not yet started developing breasts, but her pubic and axillary hair is normal. Now, if we go and sort of evaluate, this is the set of blood tests I would generally get in all people who present with sort of delayed puberty. At least get a fasting blood sugar and HbA1c. Definitely check a TSH and a free T4. In this case, it was normal. I would get an LH, FSH, estradiol, and a prolactin. So LH and FSH in this case is very low. For a 16-year-old girl, this is below the lower limit of normal. A hemoglobin, I think, is a reasonable, at least a screening test in our country to make sure it's not severe anemia. Prolactin is debatable, but I just go ahead and get it with all the other initial tests, and estradiol, which is also low. So what is this telling us, the whole clinical picture? The fact that the pubic and axillary hair is present means that there is hypothalamic pituitary adrenal axis is working well, and that there is no androgen resistance. The breast development is absent, which means that the estrogen action is absent. Ultrasound abdomen shows a small uterus. All it means is that the uterus has not yet started to develop, again because of the lack of estrogen. The low LH FSH gives the diagnosis. It means that it is hypogonadotropic hypogonadism, which may or may not be part of the complete hypopituitarism, or it could be just isolated hypogonadotropic hypogonadism. So again, we should not be misled by the fact that the uterus is small. Uterus is small because LH FSH and estrogen has not yet started developing. Now, moving on to the next case, let's say we get a 15-year-old female who presents to us again with the same complaint, not yet starting her periods. In this case, her height is less than the 3rd centile, weight is within the normal range, and physical exam suggests some other criteria of what will ultimately turn out to be Turner syndrome. For example, she had an increased carrying angle. She had a 4/6 systolic murmur over the aortic area. The sexual maturity rating shows that the breasts have not yet started developing, but there is normal axillary and pubic hair. Ultrasound, again, small uterus with no ovaries visualized. Now, in this case, if you sort of go and look at the values, her HbA1c is at the upper limit of normal. Thyroid axis shows a slightly elevated TSH. However, this is where we get the diagnostic clue. LH is elevated, FSH is very elevated, and estradiol is low. So what does this all mean? Pubic axillary hair present, adrenal glands working well, no androgen resistance. Breast development absent, no estrogen action. Ultrasound abdomen, small uterus, again, no estrogen action as yet. High LH-FSH means that the ovaries are not working, so ovarian dysgenesis. So this is a case of primary ovarian failure. It could be Turner syndrome. And the way we sort of get a clinical clue is if they are very short, it's more likely to be Turner syndrome. If they are of normal height, more likely to be primary ovarian failure. However, we do need to get a karyotype in all cases. It is suggested that we get a karyotype in all women in whom a diagnosis of premature ovarian failure is made, even in older women. Sometimes a diagnosis can be made only at the age of 25 or 28 years. The recommendation is for all women below the age of 35 years, we get a POF, or even an isolated short stature, we do have to check a karyotype. And high LH-FSH may be evident, sometimes even in girls as young as, say, 10 years or 12 years. Definitely by the age of 13 or 14, LH-FSH will be high. So that gives the clinching diagnosis. The karyotype, the specific type of karyotype, for example, it might be a 45X alone, which is seen in 45%. Always we need to evaluate for the presence of Y chromosome material because these people need gonadectomy by the age of 15 or 16 years. There may be mosaicism, which is the next most common type of karyotype, which is a mosaic of 45X and 46XX. These tend to have a milder phenotype. Or if you have just deletion of the short or the long arm of X, but the karyotype will come back as 46XX, but with a deletion of the isolated short arm. In these cases, the phenotype is very mild. Or if you have an extra copy of the long arm, so that's what is referred to as isochromal XQ. One X is completely the normal, the other X has two copies of the long arm. This karyotype is associated with a higher chance of autoimmune disorder. So we need to be aware a little bit at least of the karyotype and the phenotype correlation. And why is it important to diagnose Turner syndrome in a premature ovarian failure? Because they have other associated problems, like they may have hearing difficulty, they have thyroid difficulty. For example, in the case I presented, she is hypothyroid. She is already having some amount of impaired glucose tolerance. They're at higher risk of diabetes. They may be at higher risk of other autoimmune diseases like celiac disease. So they have to be screened for this every 2 to 5 years. They tend to have dental issues. So there is a range of other things that is associated with the premature ovarian failure and Turner syndrome. So it's very important that we do not miss this diagnosis and just put it down to premature ovarian failure. You need a proper karyotyping done and understand what that karyotype means. Now, I presented 2 cases, hypogonadotropic hypogonadism and a hypergonadotropic, in which was maybe Turner syndrome. Now, moving on to the third clinical scenario. A 15-year-old girl brought in for amenorrhea. Her height is well within the normal range, 50th centile, weight is in the normal range. Sexual maturity rating shows that her breasts are Tanner 5, well developed, and axillary and pubic hair is present. And if you look at her lab values, you can see that her sugars are normal, thyroid is normal, LH-FSH is normal, estradiol is normal. In this case, the ultrasound abdomen is showing a small uterus and the ovaries are not visualized. This is a common report that we get. So what might this indicate? Again, let us work through it. Pubic and axillary hair present means the adrenal glands are working well. There is no androgen resistance. Breast development present means the estrogen is present and working well. Normal LH-FSH means the HPO axis is normal. So why then does the uterus look small? This is where we need to diagnose Mullerian agenesis and go on to an MRI to confirm the diagnosis. Ultrasound done by specialists may be enough to confirm the diagnosis, but it is always better if financially feasible to confirm with a MRI. But one thing we need to keep in mind is we can only make a diagnosis of Mullerian agenesis if you have a small or absent uterus, in the presence of a normal estrogen, LH, and FSH. If the estrogen level is low, we cannot say Mullerian agenesis. So always remember to keep in mind that if the estrogen level is normal only, we should say it is Mullerian agenesis, because this is a very, very common sort of misdiagnosis that occurs. Even when estrogen level is low because of other reasons, pituitary cause or Turner syndrome cause, it is labeled as Mullerian agenesis. So always remember, only if the estrogen is normal can we label it as Mullerian agenesis. So what happens in Mullerian agenesis? At the critical point during development, the AMH is not turned off. So the Mullerian, only if the AMH is turned off will Mullerian ducts develop. If the AMH is not turned up, it will cause Mullerian agenesis. The things that develop from Mullerian ducts does not occur, but the karyotype is 46XX. Now the next clinical scenario, 15-year-old girl brought in for amenorrhea. The breasts are Tanner stage 5. She has sparse axillary and pubic hair. Her height is very good, 170 centimeters. Ultrasound abdomen, again, no visualization of uterus or ovaries. How is this different from the previous case? The sparse axillary and pubic hair, sparse or absent. The values will look the same. Normal sugars, normal thyroid, pretty much normal LH, FSH, but a low estradiol. So what is this indicative of? Remember, I said that we can only diagnose Mullerian agenesis if estrogen is normal. In this case, estrogen is low. And the fact that the pubic hair and axillary hair is absent or sparse means that it is indicative of androgen resistance or androgen insensitivity, and we need karyotyping in this case. But the fact that the breast development is present, what it means is that all the testosterone that is being made by the 46XY gonads is getting converted to estrogen. So estrogen action is present, but the source of that estrogen is not a normal ovary. The source of that estrogen is a 46XY gonad. But the fact that the LH-FSH is normal means that the hypothalamic pituitary gonadal axis, ovarian axis is normal. So in this case, the karyotype will show a 46XY. And in this case, because AMH is made normally, no Mullerian duct things will develop. So this is what happens in androgen insensitivity. Again, there is a lot of confusion, but if we keep the basic pathogenesis in mind, we do not need to get confused. Now, the final case, a 14-year-old girl who's brought in by her extremely distraught mother because her periods have not started. An evaluation by a gynecologist showed a very small uterus, and she was told that she would not get her periods as a uterus has not developed from birth. Basically, she was told that she had a Mullerian agenesis. When I saw her, the significant features on physical exam were that there was significant acanthosis seen. Her breasts were Tanner 2. She had normal axillary and pubic hair. And she had evidence of being overweight or even obese. Her height was at the 75th centile, weight was more than the 95th centile. HbA1c was at the upper limit of normal. And what gives a clue as to why this may not be Mullerian agenesis is that the LH-FSH is still remaining low normal. Estradiol is normal, but not very low. And remember, I said to diagnose Mullerian agenesis, estradiol has to be very, very normal range. So what is this? Again, if we go through the diagnostic algorithm, pubic axillary hair present, no androgen resistance. Breast development started, so estrogen action is present. Ultrasound abdomen, small uterus means that there is lack of maturation of the HPO axis because the LH-FSH is still not primed fully. It does not come into the normal range. So in this case, the diagnosis was insulin resistance. If she started getting her periods, she would have already presented as PCOS. The fact that she didn't get her periods means that she's presenting as primary amenorrhea. So insulin resistance, you need normal insulin action for proper development of the hypothalamic pituitary ovarian axis. So severe insulin resistance may also present as delayed puberty, even primary amenorrhea, or even a small uterus. So until we treat that severe insulin resistance, we cannot label this girl as Mullerian agenesis. So how do we manage all of these things? In hypogonadotropic hypogonadism, pituitary cause, premature ovarian failure, Turner's, the management is the same. You put them on estrogen till the uterus increases in size and spotting starts increasing. Then you replace with estrogen with progesterone, either a pill or estrogen, whatever. In insulin resistance, exercise and metformin, very rarely do we consider using estrogen replacement just to sort of kickstart the pubertal process. But remember, even in this case, unless the uterus is increased in size, it may not be capable of responding to your estrogen replacement. So in the case that I presented of that 14-year-old girl, I think she was 13 and a half, I just put her on metformin and exercise and no estrogen. It took about 2.5 years of regular exercise and regular metformin use and periodic ultrasound to demonstrate to the anxious parents that the uterus is increasing in size. And just before the lockdown, she started menstruating, and now her periods are very regular. And all we did was put her on metformin and exercise, and she was cured. So this is a very important cause. More and more, we will be seeing this of primary amenorrhea to keep in mind. How do we manage Mullerian agenesis? There is no treatment for it, only counseling. Androgen insensitivity, presence of any Y material. Remember that we need to get a gonadectomy done at least by the age of 14 to 16 years, and then you replace with estrogen so that breast development is maintained. A couple of words about counseling. Delivering diagnosis like premature ovarian failure, androgen insensitivity, Turner's syndrome, Mullerian agenesis is never ever easy. It is a very devastating diagnosis sometimes to make. I try to stay focused on the positives. Most important, I try not to talk with the children present. In our country, sometimes that sensitivity towards children is not there. You know, children of 12 and 13 are brought in, and in front of them, the parents ask, thinking that their children are like 1 or 2 years and don't understand language. That is absolutely not right. So I bring the parents in alone before I deliver the diagnosis, and I talk about fertility aspects and what it involves for future health. So if the girls have questions, I tell them to bring them in so that we can talk about it appropriately. But in general, I prefer to talk about the diagnosis and implication when the children are above 18 to 20 years, when they have sort of the maturity to deal with a diagnosis like this, and you may need to refer them for counseling appropriately. Fertility counseling, I always refer to the specialists. If it's hypogonadotropic hypogonadism, that is relatively simple. Anything else, egg donation, surrogacy, it is better that they go to a fertility specialist to understand what are the options available and do it before marriage. And a very common question that is asked is, do we need to mention this condition before marriage to the boys' side? And always that is a personal decision. I don't think as doctors we have any right to say do it or don't do it. That is a choice left to them. And all of these are part of the things that we need to do when we make a diagnosis like, say, androgen insensitivity or Mullerian agenesis. It is a very, very difficult diagnosis to deliver. I'm going to stop here by coming back to my initial slide. Remember that amenorrhea is a symptom, not a disease. You need a diagnosis. Just go through the various sort of the systematic approaches that I talked about and determine whether it is just part of delayed puberty or anatomic issues or androgen resistance. And if we approach it as in the systematic manner, diagnosis will be easy. I'll stop here and thank you very much for joining us today. Sorry, 1 minute. I'm just trying to. I'm sorry, my mouse is stuck. Just give me a minute. Can you undo my stop share, please? My screen is frozen. Yeah, thank you.
Thank you, ma'am. That was an excellent session on primary amenorrhea. And you've chosen the correct methodology of how we can, that case method teaching. I think it helped us to really understand the various causes and how to evaluate the various types of primary amenorrhea girls, actually. And you have touched the topic of emotional counseling, which is much needed for these girls also, because I think we have to be more reserved, or when we give this diagnosis to the patients in front of their parents. I think we should think twice how to make our words and tell them, so that, as you told, that we have to talk only in a positive way, because everything has got a solution nowadays. Nothing is impossible. Thank you, ma'am. Any questions from the audience? Or I think we can have it at the end of the session, ma'am, if it's okay with you.
I actually have to go for another talk, sorry. So
okay, ma'am. So
I think Dr. Shruti had a comment. Shall I just read it out?
Yes, ma'am.
Dr. Shruti Chandrasekharan, it's really a comment. Unfortunately, in androgen insensitivity, they want to be raised as males. True, Shruti. Their brain says that they are male, though putting them on estrogen is a lot easier in reality. They all want to be raised as male. I have attended a couple of intersex meetings, and almost all AIS want to be male and not female. That is the most difficult interaction to have in AIS. Yeah. Thanks, Shruti. I mean, you have a lot of experience with this, and yeah, yeah, absolutely. So how do you deal with it in that case? What have you suggested?
I mean, right now I have 2 or 3 AIs who are in the gonadectomy phase right now. So what we have decided is to try maybe a high dose of testosterone. One is a partial AIS. So to see if that works, because all of them have been counseled that, putting them on testosterone may not really, work. We have told them that a couple of times. But even with a gonadectomy, it's very difficult to convince them because they don't want to take their gonads out. They still feel that they're biologically male, even though they look like female and, they present to us with primary amenorrhea. So it's a very difficult situation. I think we have met a couple of times. So I don't have an answer to that, Jayashree. I mean, I think over a period of time, I can probably answer that question. But right now, all 3 of them are in the phase where they're waiting for gonadectomy and they are at 17 and 18 and 22. Yeah. So what I'm going to do with them with the appearance is very difficult. But they do dress up as male. They look very female. They have a close boy cut. They dress up as male. They behave like a male. They have, some of them even have female partners sexually. So but how do I look them? In transgender, it's very easy. The appearance can change immediately. With intersex, with AIS, it's very difficult to make them look like a male. So I don't know what I'm going to do, but I'll tell you maybe in a few years.
Thank you, Dr.
Sundar Raman. Can I add a comment, please?
Yes, sir.
Yeah, it is a very good overview about the primary amenorrhea. As Sudhi has told, I had a lot of cases of AS, and normally we raise them only as females. We don't raise as males, except in cases where there is a 5-alpha reductase in this thing, or it is going to be a partial androgen insufficiency syndrome, where we can raise as a male. Otherwise, I think what Jayashree is told, that it's better to raise them as a female.
Thank you, sir, for sharing your thoughts. So I will ask my co-chairperson to continue with the session.
So good morning, one and all. So the next session for today, so it's going to be a debate on inositols for PCOS, whether it is a hope or hype for these patients. So first on, we welcome Dr. Swaramya, who is a gynecologist. Whose specific focus is on research in PCOS and metabolic syndrome. She is from Pondicherry, and she has many academic accomplishments to her credit. She is a gold medalist in her undergraduate days, and also she has an award of excellence in her MBBS period. And she also has publications in metabolic syndrome in women with polycystic ovary syndrome. So over to you, Dr. Swaramya, ma'am.
Yeah, thank you so much for the introduction. Can I start my screen sharing? Could you please enable it?
Yeah.
Yeah.
You can share now.
Yeah, so you can see my screen now?
Yes, ma'am.
Yeah. So, yes, so this whole talk is about inositols and polycystic ovarian syndrome, and I'm here to say, yes, there is a lot of hope for it. So, good morning, all of you. When I was initially offered this debate topic, I was like, wow. So
You really want me to say, yes, there is hope for inositols in PCOS? I'm like, okay, yeah, I've probably got an easy topic to discuss about. So why is there so much discussion about what to do for PCOS? Because the search goes on and on for the wonder drug. We're still looking for the magic bullet in PCOS. But why PCOS? I think probably all of us know, right? The implications of PCOS is just beyond irregular periods now, the long-term consequences of metabolic syndrome, obesity, cardiovascular outcomes in terms of malignancies, breast cancer and endometrial cancer, the psychological implications. I think the impact of PCOS now is understood to be beyond just reproductive and gynecological outcomes. Our conventional approach has been to say, okay, so you're coming to me with PCOS now. What do you want to do? Oh, yes, please, first figure out your diet, figure out a proper exercise regimen. Lifestyle modification is of paramount importance. That's where you need to go to first. Well, let's get honest here, okay? However much I would like to say lifestyle modification is probably the most crucial intervention in PCOS. It's not always possible, and probably as an isolated intervention, it may not be enough, okay? Okay, metformin is there. It works well. It helps in the insulin sensitizing phase. It helps in regularizing periods. It improves ovulation. It's an extensively studied drug. There's a lot of cardiovascular outcomes that are favorable in favor of metformin. Why do you want inositols? Is there something beyond metformin? Is there something better than metformin? The whole point is that how much compliance can you really expect from metformin, considering that there is quite a significant adverse effect profile in terms of what it does to your GI system and patient acceptance. Is it something that you need to administer long term? So probably it has not ticked all our boxes in what could be an ideal intervention in PCOS. So that's why we are looking for something beyond and better than what we already have. So primarily, when we're talking about inositols, we need to know whether it actually addresses what the pathogenesis of PCOS is presumed to be. And the second half is about, okay, it's not only about the pathogenesis. Now you've told me, okay, the pathogenesis is relevant, but you really see when inositols are used as an outcome, is there a measurable clinical outcome when you use inositols? So let's just answer this one by one. A very, very familiar concept to all of us, especially metabolically, about insulin resistance and how inositols are involved in the intracellular signaling pathways. And this intracellular signaling pathways not only holds good in the general physiological system in the body, but specifically in the ovary also, right? So now, is inositol, we know now that the pathogenesis of PCOS has probably, we're coming to a consensus that it is all about insulin resistance, both in the peripheral system as well as in the ovaries. Now, is inositol dysregulation really involved in nurturing PCOS and causing the progressive metabolic consequences secondary to PCOS? I'm not talking about inositol supplementation, but the role of inositols in PCOS, endogenous inositols in PCOS. There is in vitro evidence that there is intracellular increased epimerase activity, and the concentrations of myoinositol and decaroinositol in follicular fluid, in the ovarian follicle or follicular fluid. These measurements tell us that there is an endogenous inositol involvement in the etiopathogenesis of PCOS. So I think we can confidently say that an ovary of a PCOS woman suffers from a specific myoinositol depletion and chiroinositol overload. So yes, now insulin resistance is a primary key pathogenesis, and there is an endogenous inositol disturbance in PCOS. So now, can exogenous inositols, now that we have determined that there is an endogenous inositol metabolic disturbance, can an exogenous inositol, therefore, as a conclusion, be considered for a further approach to PCOS? So what are we trying to answer? Are there biochemical in vivo outcomes? So after exogenous inositols are administered to a woman with PCOS, do I have definitive evidence saying that there are in vivo outcomes which I can measure and tell you, yes, my inositols are working, in terms of, is fasting insulin level increased? What about the HOMA index? What happens to the androgen levels? What happens to the sex hormone binding globulin levels? Is there evidence to say that this works? Yes. The 2013 international consensus on the use of inositols in obstetrics and gynecology tells us, yes, there is evidence that tells us that this really works. But hey, wait, there's a catch here. The consensus said that there's only one trial available, and this study was carried out in postmenopausal women. Now, can I extrapolate this to young women in their reproductive phase in early menarche? Because we're looking at something like primary prevention, right? So why am I saying that this is a valid point in my debate and actually believe that this study in postmenopausal women can be extrapolated to the younger population? I just contradicted myself, but I don't always contradict myself. But when I do, I still don't. So I'll tell you what the fallacy here is. The international consensus came out in the year 2013. So the studies that were reviewed were two studies which were carried out in 2011 and 2012. Now, it's more important to look forward and look what the recent evidence says. A meta-analysis came out in the year 2017, which analyzed subsequent randomized control trials, about 9 randomized control trials, which included nearly 500 women. So the primary outcomes of the study was about fasting insulin concentrations. Yes, there was a decrease in fasting insulin concentration noted. And secondary outcomes like HOMA index, the testosterone levels, and sex hormone binding globulin plasma levels, everything had a favorable impact. Now, the importance of this meta-analysis is that it included girls and women in the spectrum that we are more interested in, immediately after menarche and the early reproductive years. All right. I've told you about biochemical in vivo outcomes. What about the clinical outcomes? Is there a measurable clinical change that I can tell you, yes, I have started seeing a clinical improvement in these women? There is evidence in multiple studies about the improved regularity in menstrual cycle and improved ovulation rate. Now, this is an endocrine conference. I'm a gynecologist. Obviously, the first thing that I'm going to say is, wait, my menstrual cycles are okay. The ovulation is fine. I'm really happy. But is that all PCOS has to it? Regular menstrual cycles? Obviously not. So let me get to what it can do more, and things get better from here. There is improvement in the hyperandrogenism outcomes, which has been objectively measured by some studies by the standardized acne score. And also endocrine and metabolic parameters of insulin resistance have also improved, which I already mentioned to you in terms of the improved biochemical parameter outcomes. So there are multiple studies to support these support the use of inositols for these uses in metabolic outcomes. So specific to PCOS in reproductive outcomes, there is significant evidence for follicular maturation, luteal phase progesterone, and rescuing the ovarian response to endogenous gonadotropins, the reduction of hyperandrogenemia, re-establishing menstrual cyclicity and ovulation, and therefore increasing the chance of a spontaneous pregnancy. And to me, I'm a happy gynecologist. I have better fertility outcomes. So when we look at the review of studies about improvement in fertility outcomes, the quality of evidence is not as robust. I think this is something before we label it as the go-to drug for improving reproductive outcomes, we definitely need more evidence, but there are some pointers that it does improve reproductive outcomes. Now, what about gestational diabetes? Is this going, now I have let us say, an adolescent with PCOS, and I start her on inositols. I'm going to, with the intent of improving the metabolic consequences for her. She is going to become my next reproductive woman when she plans her pregnancy. Is this going to reduce lower the incidence of gestational diabetes mellitus? There are studies which tell us that there is some use for inositols in primary prevention, in the reduction of gestational diabetes in at-risk individuals who subsequently plan a pregnancy. And inositols, when started early in pregnancy, also have an effect on the subsequent development of GDM during the later course of pregnancy. Okay, all this is fine. I've been talking about girls and adolescents. I've been talking about what is the possible when these girls grow up to plan a family, what happens to the reproductive outcomes, then when they become pregnant, what happens to their metabolic outcomes during pregnancy. Yes, there is a favorable impact on gestational diabetes. When on inositols, what happens in general to their metabolic outcomes? Yes, there is a favorable impact on their insulin profile, on their metabolic profile. But what about long-term cardiovascular consequences? What about the impact on malignancies in the future? But wait, I'm here to give hope for inositols and pregnancies. I did not promise God with inositols, but inositols is relatively new to us now, probably a decade or so. To comment on chronic illnesses, on long-term metabolic consequences and cardiovascular consequences, we definitely need more time, and I'm sure time will tell. So, thank you. I think there is definitely hope for inositols in PCOS, and I probably had a bullet-proof vest on even before the debate started, because I think there is overwhelming evidence evolving which tells us that inositol definitely is here to stay and play a significant role in our management. Thank you.
Thank you, Dr. Swaramya. Thank you for that excellent discussion. So next, we'll go on to So next we'll move on to Dr. Chitra Selvan, who is going to talk about inositols and PCOS being just a hype being promoted. So Dr. Chitra Selvan is a renowned endocrinologist who has done her endocrinology from IPGMER, Kolkata in 2014. And she is currently an associate professor in endocrinology in MS Ramaya Medical College, Bangalore. And she has many publications to her credit in national and international journals. And she also has multiple achievements like A.D. Gandhi Award for Excellence in Endocrinology in 2015 and RSSEI Young Investigator Award in 2017. Over to you, ma'am.
Thank you, Endocrine Society of Tamil Nadu and Puducherry and Dr. Vijay Bhaskar Reddy for giving me this opportunity. It's extremely happy occasion for me to catch up with all of my friends from Tamil Nadu and Puducherry. Very happy to see everybody here. Thank you, Dr. Swaramya, for that lead up to which is bringing in hope for PCOS in the context of inositol use. And in COVID times, I've been given the job of destroying that hope and proving to you that it is just hype. But I am going to try and remain pragmatic because I'm aware of the fact that we have numerous gynecologists logged in and probably present the argument. as more as a review of scientific evidence which is available as of today, and not just a dogmatic argument to just win a debate. So this is the outline. I think we all agree that PCOS is unique in that we have understood so little about the pathogenesis, and we are just beginning to understand the long-term repercussions of the condition itself. And it is quite normal for us in areas with very little understanding to grapple and find anything that might be reasonable to hang on to. So I don't think the fact that we are enthusiastic, probably over enthusiastic about inositol, is misplaced at all. PCOS is a condition which is extremely rampant, and there are very few meaningful things that we can rely upon to improve outcomes. As Dr. Swaramya has highlighted, lifestyle modifications are difficult to implement, even more difficult to follow our own selves. So going back to quickly trace the connection between inositol and metabolism and endocrinology and gynecology, notice that the structure of inositol is very similar to the structure of sugar. Its widespread presence in human beings. It can be synthesized in human bodies. There are numerous isomers of inositol. The most commonly alluded to in scientific literature is myoinositol and D-chiroinositol. But there are many other isomers which exist in nature. It's very widely present in numerous food sources, predominantly noticed in beans, some fruits like orange, also present in grains like bread or wheat. But probably the endocrine or the metabolic interest rises from the fact that inositol is a precursor in phosphatidyl inositol, and myoinositol is a precursor which formulates this particular molecule. And what is phosphatidyl inositol? It is an extremely important secondary messenger in the downward cascade of numerous hormonal signaling. And as you can see in this slide, it is a very important secondary messenger in the cascade of insulin receptor. And that probably is the thread that ties inositol to PCOS. So if you can in some way contribute to increased phosphatidyl inositol levels, maybe the downstream metabolic actions of insulin can be improved upon, even in the presence of insulin resistance, which is common in PCOS. That seems to be a very simplistic view of trying to find a solution for an extremely complex condition for which we've not even understood the pathogenesis completely. Not only is it a secondary messenger for insulin and downstream pathway, it's also an important secondary messenger for lipid synthesis of relevance in this conversation, oocyte maturation, oogenesis, and cell morphogenesis. So let's talk about, so does that mean we can take inositol and use it in PCOS? Has anybody even found variations in inositol in women with PCOS? So myoinositol is excreted in the kidney when it is broken down. So there have been some preliminary reports to suggest that urinary clearance of D-chiroinositol, which is an isomer of inositol, has known to be greater in women with PCOS as compared to normal women, alluding to what Dr. Swaramya has told us, that there seems to be inositol deficiency or an increased clearance of inositol in the urine. So does that mean we can give inositol and hope for improvement in reproductive or endocrine and metabolic outcomes? So this is a Cochrane review published in 2017, which has tried to look at specific outcomes of oligoamenorrhea, subfertility, and ovulation with the use of numerous drugs which are available, whatever it is, irrespective of how difficult practicing treatment for PCOS is. We still need to base our practices on evidence. And quickly going back to the trials which have looked at ovulation, notice that the trials date back to 1999 and 2003. Draw your eyes to the number of people involved in the trials, 22 in each arm, which showed the maximum use, 6 of them showing evidence of ovulation than not. And so if we go on to conclude that there is no conclusive evidence to recommend the use of D-chiroinositol for ovulation. What about endocrine and metabolic parameters? Maybe ovulation is very complicated for us to take a look at and conclude. What about endocrine and metabolic? This is the same meta-analysis which was shown by Dr. Swaramya. I'm just going to go a little bit into the nuances of from where she's drawing that evidence. These are all the 9 trials which are included in the RCT. draw your eyes to the number of individuals included. They have even managed to publish studies in which there are 10 people in each arm. And notice the follow-up, not one study has follow-up longer than 24 weeks, okay? And take a look at how wide the varying effects of myoinositol or any form of inositol on fasting insulin is. Note the changes in testosterone. Notice how there are some studies which are on the other side of the midline, and also the change in androstenedione. And with this, they go on to conclude that there is a slight trend towards reduction of testosterone. So when you're not pausing to look into the study and the strength of the study, it's very easy to read the abstract and conclude that, oh yes, myoinositol is showing so many changes. I do not know why the endocrinologists are trying to get in my way. But recall the slide which showed you the number of patients included in the study. Gynecologists may come out at me saying, you will never understand the angst that I go through when I'm sitting with somebody who's struggling with infertility. It's easy for you to talk about metabolic outcomes, but I'm the one who's handling IVF and artificial reproductive techniques. So my troubles are unique. So has this been studied and reviewed? Yes, this is another meta-analysis which has looked at myoinositol in the specific context of fertility, and this is what they found. With the use of myoinositol, there is reduced FSH dose required, lesser days of stimulation, lesser number of cancelled cycles, but no difference in clinical pregnancy rate. Very similar to the addition of metformin to improve fertility outcomes in PCOS. That's sad news, but that does not justify our use of inositol to every woman who's walking in to our clinic. There's a small twist in the tail. This is a study which looked at D-chiro-inositol at varying strengths, ranging from 300 to 2,400 milligrams daily. And what they found was disturbing, that in the groups which received a higher dose of D-chiro-inositol, there was actually a lower number of mature oocytes. This is what is referred to as DCI paradox, that is D-chiro-inositol paradox. So when you go on increasing the dose of D-chiro-inositol, it actually seems to have detrimental outcomes. All of this seems to highlight the fact that there is no clear evidence. There's also some evidence to suggest that it could actually be detrimental. So what are we actually missing? And this is how I have destroyed hope right up to this point. But now I am trying to probably present data which is building up towards inositol and the level of evidence that is actually available. So there is an enzyme called as epimerase, which converts myoinositol to D-chiro-inositol. And the trick happens to be in this particular enzyme and the varying ratio between myoinositol and D-chiro-inositol. So this is a study which looked at ovarian theca cells between women who had PCOS and women who did not have PCOS. And what they found was this, that there is seen to be an increased epimerase activity in women with PCOS, which translates into a ratio of myoinositol and chiroinositol, which is lower in women with PCOS than in women who do not have PCOS. So probably the trick is not about whether you're giving inositol or not, whether you're giving a high dose of D-chiro-inositol or not, probably that there is a specific ratio of myoinositol and D-chiro-inositol which you should be probably looking at. This is a mouse model study which did exactly that, replaced myoinositol and D-chiro-inositol in 40:1 ratio, and found that there was some improvement in the histological changes of the ovaries in mice. Of course, this is a mice model study, but this is a biological plausibility study. So this is the hypothesis that they have, that probably the ratio is what is crucial. And this is where there is probably like an absolute small glimmer of hope. This is a very recently published paper which took a look at metabolic change due to combined treatment of myoinositol and D-chiro-inositol, which is a pilot study which took at metabolomics. Now, I am not the person to interpret this for you, but there is a trend to suggest that there might be some improvement with the use of the specific combination. Does this mean we can go about and use this in all people we have? Absolutely not. But does that mean there is some need here to specifically focus on this and study this more? Definitely yes. What do the recommendations say? These are the recommendations published in late 2018. Everybody who has a say in reproductive endocrinology is here. You have ASRM, you have the European Society, And in a quick summary of everything that there is available about inositol, that they conclude that it should be only considered as an experimental therapy in PCOS, with emerging evidence of efficacy highlighting the need for further research, right? So if you're practicing evidence-based medicine, this is probably the only slide that you should take away from this entire debate. And I understand that these are difficult times. I understand PCOS is difficult. I understand we are almost in a desert when it comes to options which are available. Is there a biological plausibility? Probably yes. What about the review of evidence as of today? There is no evidence to suggest that it causes meaningful endocrine or metabolic outcomes, no changes in fertility outcomes. Yes, of course, there's a Breaking Bad connection here. Maybe the ratio is what is altered. But does that mean if you replace D-chiroanositol, it's all good? Maybe not. Maybe you're causing some harm just by replacing high doses of D-chiroanositol. And the guidelines and recommendations are absolutely clear that it is an experimental therapy. Just because we're in a desert does not mean we run towards anything which looks like water. We still need to hold on to our senses and wait for something meaningful to emerge. That's my argument. Thank you so much for the audience. And I hand over back to our chairperson.
Thank you, Dr. Chitra. That was an excellent argument, and that was a very spicy debate which has gone on. Thank you very much, both of you. I think we'll put up the questions at the end of the session, and we'll move on to the next session of the day. I think Dr. Usha Sriram will be carrying on the next session. I think she doesn't need any introduction at all. She's a very renowned endocrinologist, and she's been a role model for all of us young endocrinologists. She is currently the head of the Department of Diabetes and Endocrinology in Voluntary Health Services, Chennai. And she is the founder of DIVAS, a non-profit organization working to prevent diabetes and non-communicable diseases in girls and women. And she has multiple publications on osteoporosis, gestational diabetes, and diabetes in women. Thank you very much, ma'am. Over to you.
Thank you so much for the kind introduction. It's so exciting to be part of Trendo. I'm going to share my slides, and I think you can you see them now?
Yes, ma'am.
Okay. So the talk that has been given to me is menopause, from pause to play. Okay. So first thing I'm going to tell you is a little overview of what's going to be my talk, like what is menopause and hormonal changes, physical and mental health issues, especially in the short term, and then in the long term, and a wellness program after the menopause. But let me start with this. Me, no pause. That's what I want to say about menopause, because menopause is natural, it's inevitable, and it can be actually quite liberating for a lot of people, because no more menstrual cycles, no more worry about getting pregnant, and no more worry about having to not attend temples or weddings, or I'm just saying, socially many people feel liberated. And then some people also get a lot of relief from certain health issues as well. However, menopausal symptoms can be variable in people. It's transient, and it's mostly mild in people. The purpose of this talk is actually to, for those younger doctors who may not have the lived-in experience of menopause, and of course our male colleagues who do not go through menopause, the talking points and how they can address this particular issue. Menopause is written a lot in journals and magazines, and is a butt of all kinds of jokes, as you can see. My particular favorite, of course, it says, "I'm still hot, it's just coming in flashes now." But I want to also show you menstruation, menopause, mental breakdowns, and notice how all of women's problems begin with men, just on a lighter note. So very important why we need to talk about menopause is the age at menopause has remained the same for decades, and in fact centuries. Even the Manu Shastra talks about it. So it is around 50. In Indian women, it is somewhere between 47 and 53, closer to 47, 48. But what has changed a lot is female life expectancy. When women were living only into their 50s and early 60s now live well into 80s and 90s. So you can imagine that a great portion of the post-menopausal years are going to be, a great portion of their life is going to be after the menopause. And menopause is, though it's, we think of it as some finite event. One morning you wake up and you are now postmenopausal. Doesn't happen like that. There's a transition which can happen over a period of usually, 4 years. But you can see that what's happening to the hormone levels, whether it's LH, FSH, or estradiol. The LH and FSH are going up. The estrone and estradiol are coming up, but not abruptly, gradually over a period of time. So during this continuum that takes reproductive age women from regular cyclical predictable menstruation to a final menstrual period, and if a woman has not had a cycle for 12 months, she's considered as menopausal, or if she hasn't had it for a few months and if the FSH is high, also considered menopausal. There are many symptoms attributable to menopause, most common one being vasomotor symptoms, or it can be genitourinary syndrome, typically happens a few years after the menopause, sleep disturbance, which is really actually vasomotor symptoms happening at night, sexual dysfunction, which can be partly due to the genitourinary symptoms or partly due to other things going on in life. Then skin, hair, and special symptoms, again, variable effects. And people can have a lot of fibromyalgia-like symptoms, probably linked to sleep deprivation or weight gain. And then today, what I'm going to spend a lot of time is on memory, mood, depression, and how cognition and how we can actually improve brain health in women postmenopausally. Quickly, with a clinical scenario, Miss M is a 51-year-old high school teacher. Last menstrual period was 9 months ago. She's been forgetting names of old students and colleagues. She's had a long history of migraine. She's very stable and actually migraine-free for a while. Suddenly, she's having more frequent migraines, especially at work. She's very emotionally, very embarrassed about it and quite upset. Is this going to be the way things are going to be going forward? Sleeping poorly, frequent waking up, and then has trouble falling asleep. And then she feels stressed and wonders if it's all downhill from here. So typically what influences what causes cognitive impairment in peri and postmenopausal women are the estrogen decline, which can lead to sleep problems, can lead to depression, can lead to hot flashes, and they can all then feed into the cognitive impairment. Now, 62% of women in a big Seattle midlife women's clinic reported, just 1 second, let me move this, reported noticeable decline in their cognitive performance following menopause. The most common complaints were difficulty recalling words or numbers and needing memory aids. And this is very disturbing for a lot of women, what actually many refer to as menofog. So even the learned suffer. This was 151 female faculty members in a large New York school who reported memory complaints. Then can we give them hormones and will things improve? Unfortunately, hormone therapy was not effective at enhancing cognitive performance in 9 of these studies, all of which included samples from older women, usually about 10 years beyond menopause. When they took women in the earlier years, also cognitive function was never improved with hormone therapy. As you can see, it doesn't help the hormone therapy. But what unfortunately happened was in the big Women's Health Initiative memory study, the people who were on estrogen and progesterone long term were actually having a higher risk of dementia on hormone therapy than people who were not on it. And this Ms. M also complained of sleep issues. I just want to show you prevalence of hot flashes correlates with the prevalence of insomnia. And menopausal women spend longer time awake at night and have lower sleep efficiency. And all of this circles back and feeds back into their general health. So in summary, for this part, menopause may be associated with changes in memory and sleep. Sleep disturbances may increase migraine, seizure, fibromyalgia frequency. And sleep aids or hormone therapy can be tried in the short term, but I just showed you that it really doesn't help in cognitive decline and has not been helped by hormone therapy. We also know that body composition changes happen during the menopause. There's an average weight gain of about 2 to 2.5 kilos, and it's a central fat distribution, and it's associated with metabolic syndrome, hot flashes, sleep deprivation, and a sedentary lifestyle. And a decrease in muscle mass also happens, and resistance training works usually well for this. So what is important for us to know is that obesity is associated with shrinking of the brain, with reduced brain volume, slows cognitive function, and brain of overweight and obese individuals also seem to age more. So this again is an important tool that we can use to counsel our patients to stay healthy. So which brings me to the title of our talk, which says from pause to play, but I want to say it's pause to power play, because by the time a woman reaches menopause, okay, she has gone through a lot in life. The children are probably settled, and or at least in a different place in their life. They are doing well in life. So she's now can move on. The power of purpose is there. The power of judgment is there. The power of contentment is there, and the power of lived experiences. All of which I would like to say, it's actually pause to power play. And this is not just my imagination, but actually the middle-aged brain has developed powerful systems that cut through the intricacies of complex problems to find concrete answers. It more calmly manages emotions and information, more nimble, more flexible, even cheerier. So on 4 of 6 key mental abilities, the peak actually comes in midlife. You can size up situations better, draw the connections, see the wider context, and therefore the better judgment. That's why I said there's better judgment, and appreciate subtlety and ambivalence. So in research on wisdom, what it is and who has it, concluded it peaks about age 65 after a sustained accumulation through midlife. So this is really important piece of information that we need to share with our patients, telling them that it's not all downhill from there. It's a transient thing, what you're going through. You will recover, bounce back, and actually move on to a better phase in one's life. So myelin, the crucial fatty tissue that's coating the nerve fibers, which is making the brain work, myelin continues to increase well into midlife, and it can grow even past age 60. Now coming to the mind itself, the mind is an element or a complex of elements in an individual, how we think, we perceive, reasoning. So we use the mind in a state of mind, out of our mind, mindful of behavior, mindfulness, mind over matter, mindlessly busy. We use mind in all so many ways, not in our right mind. So what actually happens during menopause? So I just want to show you mind, mood, and the menopause. So this good kind doctor says you need strong medicine. I'm prescribing chocolate. So I want this doctor. So what happens is your hormones can't decide if they're coming or going. I mean, it's all over the place. So mood swings, emotional health is linked to our hormones. And if they interact with brain neurotransmitters such as serotonin and GABA, both of these neurochemicals are implicated in depression, PMS, and anxiety reactions. The next is sleep. You toss and turn most of the night, and that's not good for your mood and sleep issues. Plus, sleep apnea increases the prevalence of sleep apnea with menopause, significantly higher worse sleep index compared to premenopausal subjects. So estrogen and progesterone help protect younger women from what we think of as male breathing disorders, such as sleep apnea and snoring. So once these hormones come down, you can see that they become more susceptible to these kind of sleep apnea kind of disorders. So when people have sleep apnea, brain volume goes down. So again, something to keep in mind about how treatment needs to be done for this. So what can you do for the mood? Will hormone therapy help in the control in the keeps cognitive and affective disorder? While it did not alter cognition, there was beneficial mood effects for a small to medium kind of symptoms, were noted in 4 years of oral conjugated equine estrogen. But then we also know the longer you give conjugated equine estrogen, we are going to run into other troubles like breast cancer or possibly cardiovascular problems. Then just the fact, who likes, finding it harder to get older. So as this person says, I'm a victim of identity theft. Menopause took a happy, slim, sexy woman and turned her into me. So every day you may notice a new wrinkle, you may gain weight despite working out harder than ever, or find some facial hair. Children may be teenagers who don't want to spend time with you, or your spouse may be going through his own midlife crisis, and suddenly you feel you're like invisible to the opposite sex. So why is all this important? Is I just want to very clearly establish here, premenopausal woman is woman plus estrogen. Take a postmenopausal woman and you put her on estrogen, she will not become a premenopausal woman because the body is going through many other changes. And socially, psychologically, there are many other things going on as well. One of the important things is, caring for parents, aging parents, which can be daunting. Caring for parents on the one hand, caring for the children on the other hand, people can get pulled in many different directions because you're juggling so many things. Now, coming to vasomotor symptoms itself, one of the things we really want to tell our patients is we cannot tell them, okay, it'll all go away in a few months, or if they come back 5 years after menopause and say, I feel hot and I have hot flushes, we can't dismiss it. It's their narrative. And as you can see from this slide, a significant number of women continue to have menopausal vasomotor flushes even 10 to 15 years after their last menstrual period. So we need to keep that in mind. While majority will get better in a short period of time, probably within 2 years, there is a significant number. 10% can last 10 years, 15 years, and another 10 to 15% can last up to 10 years. So women with more hot flushes seem to be experiencing more cognitive deficits and more memory and attention complaints. So we need to do what we can to help them. And as I just want to show you, cooler rooms, cotton, loose clothes, plenty of water, consider yoga, meditation, and non-hormonal therapies like venlafaxine, and definitely hormone therapy for some, especially those who have gone through surgical menopauses, who have gone through things abruptly, or much younger women, or definitely those whose quality of life is really bad. And stress reduction is very important in women who are going through the menopause. Again, I want to show you what stress does to the brain cells in the hippocampus. And depression is very common. And women as such are more prone to depression, and estrogen withdrawal seems to, especially in women with a previous history of episodes of depression, when they go through the menopause, they may have more depression. And there's a domino effect. They have more depression, sleep disorder, therefore more somatic symptoms. And it's a bi-directional relationship. And of course, the life stage perspective of where they are in terms of changing family or professional roles, interpersonal losses, aging, and physical illness. And then what does depression do to the brain? The number of days of depression, again, is associated with hippocampal atrophy. I want you to remember this hippocampus because we're going to come back to that. And it's associated with impaired memory, executive function, and processing. So you want to take this woman who is going through the menopause or postmenopausal and give her a wellness prescription. It's exercise and eat healthy. Find a self-calming skill to practice, such as yoga, meditation, rhythmic breathing, mindfulness. Avoid tranquilizers and alcohol. Engage in a creative outlet that fosters a sense of achievement, new hobby, reinventing oneself. But I personally think that staying connected with your family, your girlfriends, your community, nurture your friendships, practice mindfulness, and a tailored short-term hormone therapy for those with vasomotor symptoms or those with premature menopause or surgical menopause. Because I just want to show you when you take hormone replacement therapy, while there is some benefit, definitely benefit in terms of fracture reduction, and there is a decrease in colorectal cancer. If you take everything else, coronary artery disease, invasive breast cancer, all of those things seem to be worsened and then of course all the stroke and pulmonary embolism, deep vein thrombosis. We definitely seem to keep all of this in mind when prescribing hormone therapy, because women need to come back for their follow-up and surveillance. I'm going to try and wrap this up quickly with a brain wellness program that I've been very impressed by. So this brain wellness program, I wanted to talk about the hippocampus. You know where the hippocampus is, and this is a beautiful picture of that. And so in this comprehensive program, what they do is they evaluate the brain function. They do things from neurocognitive evaluation to cardiopulmonary testing, sleep health assessment. And then basically what they prescribe is really not medications. If you've see there, a lot of yoga and meditation and exercise, cognitive cells, memory training, neurofeedback, then progress monitoring, then diet and lifestyle coaching. And what does all this do? Is this beneficial? And I just want to show you. Before, that is the size of the hippocampus. And after something as simple as this therapy, you can see the size of the hippocampus going up. So I think the onus is on us to tell our patients about good nutrition, physical activity, yoga, meditation, mindfulness, and all those other things that I talked about. And now, on the one hand, this is the brain health, but we also are looking at the entire woman and not just as one part of her and try to fix that with medication or hormone therapy. We all know that the bone loss is very significant, accelerated around menopause, and aging also increases risk of fractures. So we want to give them bone health tips as well. Healthy eating with protein, calcium, vitamin D, physical activity with weight bearing, sunlight exposure, no smoking, alcohol in moderation or avoid it totally. Excess caffeine should be avoided. And in Indian patients, BMD testing should begin at 55 or 5 years after menopause, whichever comes first. Know your risk for osteoporosis and fall prevention, really most important, and osteoporosis medications when indicated. When it comes to heart health, we know that the postmenopausal time is very important. In 10 years, the protection that women have in the premenopausal years is lost once she gets into the menopause. So it's really important for us to counsel our women about heart health. And I have highlighted what's important in red: building relationships, not being lonely, screening for diabetes, hypertension, dyslipidemia, and being aware that symptoms are different in women with heart attack and heart issues, and of course, use of aspirin and other medications only based on clinical indication. And genitourinary atrophy usually happens years later, can be treated by local vaginal estrogen. Occasionally, people may need more therapy for that, but usually can be managed with topical estrogen. I'll end here, and I just also want to say that we are going to be launching a new program called Unmute Yourself, which is primarily for women to speak up, use their voice, whether it is menopause or whether they're going through issues throughout their life. So I want to thank Trendo for this great opportunity. Thank you so much.
Thank you, Dr. Usha ma'am. That was a very enlightening session, not only focusing on the usual aspects of menopause, but also on the depression and insomnia, which aspects are less talked about. And like many patients are feeling like very low, and they don't want to come out and tell all these issues in front of the family. They think that they'll be labeled as it is all just because of the hormones, and they'll be sidelined. So thanks for the enlightening talk. Ma'am, I think we have time for a few questions. So the first question is to you, ma'am. So what is the call on the word andropause, whether it's a myth or a reality?
It's not a myth. Men also go through if that's what they're referring to, or is it the lowering of male hormone levels in women? So I think maybe they're referring to in men. It's just later, usually around 65-ish or so. And it's not so abrupt as in, there's no dramatic event like a last menstrual period. It's just a gradual decline of testosterone, a gradual decline of sexual feelings and sexual function, and maybe associated also with body composition changes and some muscle mass decrease.
Okay, ma'am. Thank you. Is Dr. Swaramya available? If she's available, can... No, I don't think so.
Hello,
So,
I'm Dr. Sundaraman. Can I come in?
yes, sir. Yes, sir.
Yeah,
Sure,
that
please.
was a wonderful talk, Dr. Usha.
Thank you.
I just want your comment. It's quite interesting that if you see in the extremes of the reproductive age group, from the puberty to the menopause, in the puberty, you have an LH rise initially, whereas in a menopause, you got FSH rise initially. Now, whether this has got some significance, like increased LH spikes during menopause is causing these type of menopausal hot flushes. That is why estrogen is more effective in these people. And once again, I want to reiterate that many times in treating a menopause, we forget the hormone component. After the WHI study, a lot of the gynecologists are fearing to give hormone treatment. I think you must slightly unravel this myth, and I think, what is your opinion?
So the first one is, you're absolutely right, that the rise in the LH and FSH is linked to the menopausal symptoms, and also the temperature regulation area is actually physically proximate. There's a physical proximity of that also to the area of release of the GnRH and the gonadotropin. So that is definitely a cause of that. In terms of hormone therapy, I'm just saying that it's a very specialized, nuanced treatment, and not something that we can. It was being used as in the 60s and 50s, 60s, 70s. It was more I think a feminist movement where people took a lot of estrogen was prescribed very freely, and as if it is a panacea for all menopausal problems, and women who took it would age less, their skin would be better, hair would be better, sexually better, and therefore more feminine. So they linked HRT with femininity. We know subsequent from those were all observational or data like that, but we know from RCTs that we cannot obviously mess with nature. Nature meant for us to undergo this change at this age. So by adding this after the expected age for menopause, we are not going to turn the clock back. So that is something to keep in mind, and use hormone therapy only for specific indications, like if the woman is going through hot flushes that is quite severe, or her quality of life is bad, or she is going through some genitourinary problems, and you want to prescribe some topical vaginal estrogen, and not as a preventive measure of any kind. I think that is something that we should move away from. And somebody has asked a question about food specific for menopause. So short answer, we have to stay away from all of the phytoestrogens and not prescribe them at all, because we do not know the long-term effect of those things on other tissues, short or long-term, on other tissues of the body which are estrogen responsive, because these are all phytoestrogens. So I do not prescribe this. And the reason I spend so much time on the mind, mood, and all of that is actually this is what we need for counseling the patient. Spending time with them and explaining that you may be going through these things, but not to worry, power play is coming soon. Yeah. Unmute yourself, Geeta.
Yes, ma'am. So for long, can the vasomotor symptoms happen after last menstrual period in your experience, ma'am? How long?
So I have had patients who have had it for anywhere from 5 to 10 years. So they continue to be more than hot flushes. Many of them continue to have heat intolerance. Than anything else. They said they were fine before. It's only after menopause that they become more heat intolerant and still having an occasional hot flush. But the frequent ones usually don't last more than a year to 2 years.
What about the genitourinary symptoms, ma'am? Like how do we manage as patients frequently present with them?
Like I said, vaginal estrogen works really well. I ask them to, of course, they'll have to get a pap smear before we do that. And then, plenty of hydration and also sexual activity itself increases the, the lubrication and it actually helps women. And then there are other things like drinking cranberry juice and all that. But really, vaginal estrogen works. Initially, I ask them to use it every day. For a couple of weeks or so, and then I decrease the frequency to 3 or 4 times a week. And many women are happy just using it twice a week.
Okay. So this is a question to Dr. Chitra. Is there a link between PCOS and hypothyroidism, ma'am?
PCOS and hypothyroidism, I'm not really sure if there is a connection, but it's important to understand that primary hypothyroidism is a secondary cause for PCOS. So it's important to rule out hypothyroidism, especially when somebody presents with a clinical presentation similar to PCOS. So that's one of the most common conditions. So it's prudent to rule that out. Does the diagnosis of PCOS increase your risk of hypothyroidism? I'm not sure if there's a connection that way around.
So thank you, ma'am. Ma'am, again to Dr. Usha. Ma'am, again about food. Any opinion about ginseng, red clover, and soya usage? I think it's similar.
I don't use them, and there's plenty of good evidence to say that it's just probably a placebo effect, and we also don't know what it's going to do to them otherwise. So I don't use them. Yeah. If at all it's intolerable, I use either venlafaxine or I use hormone therapy.
Ma'am, what about short-term hormone replacement therapy being given SOS, like for a very short period?
So if you're using it for vasomotor symptoms and you give it short-term and then you stop it, there's a likelihood the symptoms will come back because again, you're going through the withdrawals, right? So what you'll have to do is kind of wean them off and also empower the patient with the information that if they start feeling the symptoms again, they may feel it. And, over a period of time, it'll get better to see how it works out when we are weaning them off. So I'm comfortable using it for a year or so with no difficulty and then slowly weaning them off. This is really especially useful in surgical menopause where acutely the ovaries are removed and their hormone levels plummet so fast that they have a lot of symptoms. Most women who are going through the menopause, are having it not so severely.
Okay. Thank you, madam. Thank you very much. So I think we have had a strong, smooth sail among our cyclone here. Thank you for that wonderful session, all the speakers. Thank you very much. I would like to conclude the session with this. Thank you.